Welcome back, focused learners. Today we're diving into a brand new explainer, and we are taking a fascinating journey straight into the center of the human body to look at the ultimate high-performance engine. Yep, your heart. We're going to break down its structural hardware, its incredibly precise electrical wiring, how we run diagnostic checks on it, and what actually happens when this amazing machine needs to pull into the medical body shop for some serious repairs.
So, let's kick things off with a quick question. Do you know what this number range means for you right this very second? Well, 60 to 100 represents a normal, healthy resting sinus rhythm in beats per minute. When you do the math on that, at the top end of the range, your heart is literally firing up to 144,000 times in a single day. Think about that. It never gets a day off, it never goes to sleep, and it operates with absolutely zero resting downtime. It is just a complete miracle of biological engineering.
Section 1, Anatomy and Blood Flow. Okay, let's dive into this.
We're going to start by looking closely at the hardware and the structural mechanics of this primary engine. How is it built, and how does it move fluid with such crazy efficiency? So the heart wall is actually constructed in 3 incredibly specialized layers. On the outside, you've got the epicardium. In the middle, there's the thick myocardium muscle layer, which is the part doing the actual heavy lifting and contracting. And then, lining the inner chambers, you have the endocardium. But what really protects this whole engine from overheating and friction is the pericardial sac encasing it. Right between the layers of this sac is the pericardial space, holding just 5 to 20 milliliters of fluid. Now, I know that doesn't sound like a lot, but that tiny volume acts as an absolutely crucial continuous lubricant, cushioning the heart against trauma and infection every single time it beats.
Let's trace the plumbing. If you follow the blue pathway, oxygen-poor blood enters the right side of the heart, and that side is strictly dedicated to pumping that blood straight out to your lungs. Once it's all loaded up with fresh oxygen, it returns to the left side, following the red pathway, where the thick left ventricle powerfully pumps it out to the rest of the body. As all this fluid moves, valves snap shut to prevent any backflow, and that snapping is actually what creates your distinct heart sounds. S1 is your atrioventricular, or AV valves closing at the bottom or apex of the heart. S2 is your semilunar valves closing at the top, or base. And in some cases, you might even hear an S3 ventricular vibration or an S4 atrial contraction against a stiff ventricle, which usually tells us there's some kind of disease or injury present. Now, even though the heart is constantly filled with gallons of blood, it kinda ironically can't just absorb oxygen directly through its inner walls. It needs its own private fuel line. That's the coronary circulation wrapping right around the exterior. You have the right coronary artery and the left coronary artery, which then splits off into the left anterior descending and the circumflex arteries. So the crucial point here is if a blockage happens in one of these private fuel lines, the muscle tissue downstream literally starves. And that right there is exactly what causes a myocardial infarction, which we all commonly call a heart attack.
Section 2, the heart's wiring system. Let's transition from the physical plumbing over to the electrical wiring.
Because for a pump this complex to work, the timing just has to be flawless. And that requires built-in precision spark plugs. The electrical pathway here is pretty fascinating. The primary pacemaker of your heart is the SA node, firing away at that normal 60 to 100 beats per minute we talked about earlier. But you know, the heart is built with some amazing fail-safes. Let's say the SA node fails. Well, the AV node steps up as a backup pacemaker, though it has a slower intrinsic rate of about 40 to 60 beats per minute. From there, the signal travels down the bundle of His, splitting left and right, all the way down to the Purkinje fibers at the bottom. These fibers serve as the absolute last resort pacemaker at a pretty sluggish 20 to 40 beats per minute. So each stage down the line provides a slower but ultimately life-saving backup rhythm.
So who is actually driving this car? Well, it's your brain, using 2 very distinct sides of the autonomic nervous system. Think of them as your accelerator and your brakes. The sympathetic nervous system is your accelerator. It uses a chemical called norepinephrine to crank up your heart rate and the force of the contraction. On the flip side, your parasympathetic nervous system acts as the brakes, using acetylcholine to slow that heart rate back down and decrease the conduction.
And this brilliantly illustrates what happens when the accelerator gets stuck. If the heart rate goes way over 100 beats per minute, entering what we call tachycardia, you'd probably think, hey, it's pumping more blood, right? But actually, no. An extremely fast heart rate drastically decreases the filling time of the chambers. Because the heart literally doesn't have enough time to properly fill up with blood between those rapid beats, your overall cardiac output drops. So faster isn't always better, efficiency is really what matters here.
To monitor all of this invisible electrical activity, medical professionals use an ECG.
You can actually trace the electrical impulse directly to the waves on the readout. When the SA node depolarizes the atria, you get that small little P wave. Then, when the impulse blasts through the bundle branches to contract those massive ventricles, boom, you get the large, sharp QRS complex. Finally, the T wave represents the ventricles repolarizing, basically resetting their electrical charge for the very next beat.
Section 3. Diagnostics and Cardiac Labs.
Okay, we've seen how the engine runs. Now let's shift into the diagnostics phase of our explainer. How exactly do we check the internal warning lights when something might be going wrong? Well, when the heart muscle takes damage, it leaks specific proteins straight into the bloodstream. These are our warning lights. Troponin is absolutely our gold standard. It's highly specific to myocardial injury, and it stays elevated for over a week. CKMB also indicates damage, but that one peaks around 18 hours post-injury. Then we have myoglobin, which rises super fast, usually within 2 hours, but it's not actually specific to just the heart. And finally, there's BNP. BNP is released when the heart is overstretched. So a high BNP doesn't necessarily mean you're having a heart attack, but rather that the heart is failing to pump effectively.
Externally, we need to test the engine's performance under different conditions. On one hand, we have the Holter monitor, which is a non-invasive ECG you wear for 24 hours, just to catch any dysrhythmias hiding in your normal daily routine. On the other hand, we have the exercise stress test, which usually takes place on a treadmill. What's absolutely vital here is the prep. Patients might actually be instructed to withhold specific prescribed medications, like calcium channel blockers or beta blockers, on the day of their test. Why? Well, because you need the heart rate to actually increase during exercise so we can see exactly how the engine performs under a heavy load. Section 4. Procedures and Interventions. Let's move on and see how this all builds together. We are now entering the high-stakes world of surgical interventions. When the plumbing fails or the vessels get blocked, it is time for the mechanics to go to work. Before any major internal repair, we always start with a heart catheterization to see exactly where those blockages are. And the prep for this is strict. Patients must fast from solid foods for 6 to 8 hours beforehand. Crucially, the care team absolutely must assess for allergies, specifically looking for reactions to seafood, iodine, or radiopaque dyes. That's because that dye is exactly what allows the surgeons to see the coronary arteries vividly on an X-ray monitor. When a blockage is found, a really common fix is PTCA, or percutaneous transluminal coronary angioplasty. It breaks down into 4 mechanical steps. First, a catheter is threaded right up into the blocked artery. Second, a deflated balloon is perfectly centered inside that plaque occlusion. Third, the balloon is inflated under really high pressure to physically crush the plaque against the artery walls. And fourth, the balloon is removed, leaving behind a nice open pipe and dramatically improved blood flow.
Now, what's really interesting about visualizing the physical reality of that balloon reopening the occluded lumen is just how mechanical it is. It's a remarkably elegant solution, but, it does carry some pretty serious risks. Crushing plaque with a balloon can sometimes cause arterial dissection or even a rupture. It can also cause embolization, which is where tiny fragments of plaque break off and travel downstream. It can even trigger a coronary artery spasm. So it requires incredible precision from the surgical team.
Because a ballooned artery can sometimes just decide to collapse back down, PTCA is frequently paired with a stent. As the balloon inflates, it expands this tiny wire mesh tube. When the balloon leaves, the stent stays behind as a permanent scaffold to keep the vessel propped open. But because this is a foreign object living inside the blood vessel, acute thrombosis or clotting is a major concern. Patients are going to require strict antiplatelet therapy, using drugs like clopidogrel and aspirin for months to prevent clots from forming on that new metal framework.
Balloons and stents aren't the only tools in the shop, though. For certain blockages, surgeons might use an atherectomy. This literally features a microscopic rotating blade on a catheter that pulverizes the plaque. Or, alternatively, for smaller occlusions, they might use laser-assisted angiopathy, which uses intense heat to literally vaporize the plaque away, completely reopening the artery. But what happens when the vessels are just too small or the atherosclerosis is too widespread for traditional stents or balloons? Well, we look to a genuinely fascinating procedure called transmyocardial revascularization, or TMR. In this one, surgeons use high-powered lasers to shoot 20 to 24 tiny new channels directly through the thick wall of the left ventricle. This actually allows the oxygen-rich blood inside the chamber to seep directly into the starving heart muscle, completely bypassing those blocked surface arteries entirely. Science fiction, right? But it works. Finally, we reached the ultimate bypass procedure,
Coronary artery bypass grafting, or CABG. When medical management fails and those arteries are severely occluded, surgeons will actually take a healthy vessel from the patient's own body, often the saphenous vein from the leg or the internal mammary artery from the chest, and they literally stitch it into the heart to completely reroute the blood flow around the massive blockage. It's giving the engine a brand new, totally clean fuel line. But here is the hard truth of it all. After all these intense medical repairs, the balloons, the lasers, the stents, the bypasses, maintaining the engine falls entirely on the patient. Medical interventions fix the immediate crisis, for sure, but long-term survival requires some strict lifestyle modifications. This means immediate smoking cessation, strict adherence to a heart-healthy diet, intentional weight loss, and daily modified exercise.
We've seen exactly how beautifully complex and yet how surprisingly delicate the heart's structural machinery truly is. It is the only engine you'll ever get, running continuously for a lifetime without a single break. So, taking all of this into account, I want to leave you with this question to really think about. With everything we know about this incredible, fragile machinery, what specific lifestyle modifications will you make starting today to protect, fuel, and maintain your high-performance engine? Thank you so much for joining me on this explainer, and I will see you next time.